Hi, folks. Welcome to today's Sunday Critical Care webinar from our Young India Intensivist Forum. And today we have a very special faculty all the way from Nice, France. And he is Dr. MATHIEU JOZWAIK. He is Associate Professor Intensive Care Medicine, Medical Intensive Care Unit, Nice Teaching Hospital, France. He is Associate Editor of Annals of Intensive Care, and he has around 100 publications and several book chapters. And very importantly to the topic, his research area is heart-lung interactions, hemodynamic monitoring, pathophysiology of shock states, echocardiography, and vasopressors. And he will talk on vasopressors today, primarily about the clinical pharmacology and their use in septic shock. So I think it'll be very educative for all of us. It's a very interesting and a very useful topic, vasopressors. And we thank Dr. Jozwik for sparing his time and contributing to the teaching on our webinar. Thanks so much, guys, and we'll take any questions at the end. Over to you, Dr. Jozwik.
So, good afternoon, everyone, and thank you very much for your invitation and kind introduction. And I am delighted to be with you to discuss vasopressor over the next hour. And yes, but it doesn't work. I cannot change my slide.
Just move it from the keyboard. Sometimes that happens. Yeah.
Well, just 1 second. Yes, this is difficult. I don't know why. Just 1 second.
Yeah, so you'll have to share the screen again.
Yeah, sure. Wow. So I think you cannot see my screen.
Yeah, you are not being able to share. You were sharing initially when you joined.
Yeah, but yeah, I don't know why it does not work. The connection is so slow. Just I have to close PowerPoint.
Yeah, I think you join again. Join again.
Yeah. Just 1 minute.
Dr. Joswick, I suggest you log out and join again. Yeah, it has come. It has
Yes. It's coming.
Yeah.
So, does it work?
Yeah, great.
All right. So, sorry, I apologize. So, restart. So, I'm delighted to be with all of you to discuss about vasopressors over the next year, the next hour, and more specifically, their clinical pharmacology and their use in septic shock. I have absolutely no conflict of interest to declare to this talk. So, currently, the definition of septic shock is a combination of sepsis, hemodynamic failure requiring vasopressor administration to maintain a mean arterial pressure level above 65 millimeters of mercury, despite adequate fluid administration, and hyperlactatemia. From a pathophysiological point of view, septic shock is a vasodilatory shock characterized by a venous and arterial vasodilation, which results in relative hypovolemia and arterial hypotension. Also, a decrease in cardiac contractility can be associated in patients with sepsis-induced cardiac dysfunction. If we zoom on cells level, septic shock is also characterized by the inability of cells to increase their oxygen extraction, and that for several reasons. First, the presence of thrombi. Second, the loss of ability to recruit closed microvascular vessels and the loss of microcirculatory vasodilation because of inflammation, resulting in veno-arterial shunts. In other words, septic shock is a disease of microcirculation. My first take-home message is that norepinephrine is the first-line vasopressor currently recommended in patients with septic shock. And when we look at this international survey endorsed by the European Society of Intensive Care Medicine, over 800 intensivists were asked about their first-line vasopressor in patients with septic shock. And interestingly, almost all intensivists, 97%, used norepinephrine in accordance with current guidelines as first-line vasopressor. What about norepinephrine? In vascular smooth muscle cell, norepinephrine activates alpha-adrenergic receptor, which in turn activates intracellular signaling pathway, resulting in an increase in calcium into cytoplasm, enabling vasoconstriction. Norepinephrine is the first-line vasopressor in patients with septic shock for several reasons. First, norepinephrine improves the coronary perfusion. Here are represented the aortic pressure, the flow into the left coronary artery, and the flow into the right coronary artery. And you can see that the flow into the left coronary artery occurs during the diastolic part of the cardiac cycle. And this is easy to understand because the left coronary artery is into the wall of the left ventricle, which is sick. And the artery is therefore occluded during the left ventricular contraction. So, by increasing the diastolic arterial pressure, norepinephrine improves coronary perfusion. The second reason is that through its alpha-2 effect, norepinephrine increases cardiac preload, as illustrated in this figure by the increase in global and diastolic volume, a static marker of preload, after norepinephrine administration in patients with septic shock. And this increase in cardiac preload results from the venous vasoconstriction induced by norepinephrine, which in turn increases the stressed blood volume and therefore the systemic venous return. So the systemic venous return is defined, is driven by the pressure gradient between the upstream mean systemic pressure, which is a venous pressure when cardiac output is 0, and the downstream right atrium pressure or central venous pressure. Look at this physiological study including 16 patients with septic shock, in which the authors decreased norepinephrine dosage from 0.30 to 0.16. In this physiological study, the mean systemic pressure and the resistance to the venous pressure were estimated by plotting the relationship between the central venous pressure and cardiac output measured at two levels of positive and expiratory pressure before and during end inspiratory and end expiratory ventilator occlusions. So the authors obtain two couples of cardiac output and CVP values, and from these 2 points, assuming a linear relationship between the CVP and the cardiac output, a line could be drawn and the mean systemic pressure could be estimated as a pressure corresponding to the x-intercept of the linear regression. And the resistance to the venous return were estimated from the inverse of the slope of the regression line. What is important to see is that the lowest dose of norepinephrine was associated with the lowest mean systemic pressure and the lowest venous return. In other words, norepinephrine increases the mean systemic pressure due to venous blood redistribution from unstressed to stressed volume, and thus potentiates the systemic venous return, as will the fluid administration. Third, norepinephrine increases cardiac contractility, as illustrated by the increase in cardiac function index, a marker of cardiac contractility obtained using transpulmonary thermodilution after norepinephrine administration in patients with septic shock. And these increases in cardiac contractility concerns both the left ventricular and the right ventricular function, as evidenced by the increase in the different echocardiographic systolic parameters after norepinephrine administration. And this norepinephrine effect is related to its beta-1 effect. Finally, the last reason is that norepinephrine also improves muscle tissue oxygenation, which can be assessed at bedside by using near-infrared spectroscopy. How does it work? Briefly, a probe is placed on the thenar eminence, and the arm cuff is transiently inflated about 200 millimeters of mercury to induce ischemia. The arm cuff is then deflated and changes in STO2 and STO2 recovery slope, which is a marker of the ability to vessels to be recruited in case of ischemia, were collected. Look at the results of this study. The maneuver was performed before and after norepinephrine administration in patients with septic shock. And as you can see, STO2 was higher after norepinephrine administration as STO2 recovery slope, meaning that norepinephrine improves muscle tissue oxygenation. And these are all these properties of norepinephrine in vessels, heart, and macrocirculation, which explain why norepinephrine is currently the first-line vasopressor recommended in patients with septic shock. So now the question is, when should norepinephrine be started? Early, because of all beneficial effects of vasoconstriction on venous return and organ pressure perfusion? Or delayed because of its different side effects, either related to vasoconstriction, such as increase in cardiac afterload, or directly related to norepinephrine, such as cardiac arrhythmias. There are some sparse data in the existing literature. First, in this retrospective study, including 213 patients with septic shock, they also showed that patient prognosis was closely related to the timing of norepinephrine administration, and especially after the first 2 hours of management, with an increase of the odds ratio of death. And if you look at the left side of the slide, you can see that the risk of mortality increases when norepinephrine administration is delayed, with a risk of mortality which increases by 5.3% per hour of delay in introduction of norepinephrine. Second, always a retrospective study, but with matched group of patients. They also shows that a very early start of vasopressor, namely within 1 hour after fluid administration, might limit the amount of fluids to resuscitate septic shock patients, and therefore could lead to better clinical outcomes with a lower mortality rate. Finally, only one randomized trial has evaluated the effects of the timing of norepinephrine administration so far. The authors compared, during initial management of patients, the association of fluids and norepinephrine against fluids alone. And they found that there was a higher proportion of patients with control of shock, evidence on mean arterial pressure, diuresis, lactatemia. So there was a higher proportion of patients with controlled shock in the group of patients treated with the association fluids and norepinephrine. However, and maybe unexpectedly, the authors did not confirm previous findings on prognosis, with no effect on mortality between two groups of patients. Maybe such discrepancy might be explained by the fact that in this randomized trial, only fixed dose of norepinephrine were used. My second take-home message is that alternatives to norepinephrine should be considered only in patients with refractory septic shock. And it is only very recently that a clear definition of refractory septic shock has been proposed. Refractory septic shock is a life-threatening situation in which escalation of vasoactive therapy fails to restore adequate tissue perfusion. And at bedside, refractory shock is defined by the persistence of arterial hypertension and hypoperfusion in the absence of hypovolemia, despite patients are receiving more than 0.25 micrograms per kilogram per minute of norepinephrine. And it is very important to keep in mind that this 0.25 norepinephrine threshold is rather debatable, the confusion residing in the way the norepinephrine dosage is expressed in the different studies between norepinephrine base and norepinephrine tartrate. So, the question is, why consider alternatives to norepinephrine in patients with septic refractory shock? First, because of the vasopressor load. As illustrated in this figure, the x-axis represents quartiles of mean arterial pressure, the first y-axis 28-day mortality, and the second and the third axis, quartiles of mean vasopressor load. Whatever quartiles of mean arterial pressure, high doses of norepinephrine have been found to be directly related to mortality. And this vasopressor load and this effect of high doses of norepinephrine on patient prognosis is due to catecholamine-induced cardiac toxicity with myocardial inflammation and myocardial necrosis. The second reason is because of the potential immune effects of norepinephrine, which could participate to the sepsis-induced immunoparalysis, which is associated with poorer outcomes, such as secondary infections and, of course, mortality. So the question is how to manage a patient with refractory septic shock. The first step is to rule out differential diagnosis. That is, the persistent hypovolemia, so the presence of preload dependence should be investigated, and the presence of intracavity left ventricular obstruction, which may be favored by high doses of vasopressors. The second step consists of correcting all the factors contributing to refractory shock. As you can see in this on this slide, many clinical, biological, endocrine, or metabolic factors can contribute to the onset of refractory shock, both participating in the decrease in vasomotor tone. So you have to correct fever, to decrease sedation level, to normalize blood glucose level, calcemia level, to correct acidosis, for example. The third step is to assess the left ventricular function with echocardiography. And I'm sure you will agree that the therapeutic response is probably not the same for the patient on the left side and the slide and the patient on the right side of the slide. In the absence of left ventricular dysfunction, vasopressors, and this is the issue of this talk, vasopressors should be preferred. The question is which ones to use in these patients who are already receiving norepinephrine. First, what about dopamine? In the randomized sub-study, dopamine was compared to norepinephrine as first-line vasopressor in patients with shock, including 60% of patients with septic shock. And there was a trend in favor of norepinephrine in terms of survival, with subgroup analysis showing an increased mortality with dopamine in patients with cardiogenic shock. Nevertheless, in the whole population, patients who received dopamine had more frequently atrial fibrillation. And since the results of the sub-study, dopamine is no longer recommended in patients with shock, including in patients with septic shock. The second vasopressor one could consider it is another adrenergic vasopressor, namely epinephrine. In the randomized CAT study, epinephrine was compared to norepinephrine as first-line vasopressor in patients with septic shock, including 57% of patients with septic shock. As you can see in this figure, there was no difference between groups regarding the probability to achieve a mean arterial pressure above 70 millimeters of mercury, and that was the primary outcome of this study. If we look at other outcomes in the whole population, patients who received epinephrine had higher heart rate and hyperlactatemia compared to patients who received norepinephrine. And even if there was absolutely no difference between groups in terms of mortality, despite the adverse effects of epinephrine, epinephrine is currently not recommended not recommended, sorry, as vasopressor in patients with septic shock. What about other vasopressors, namely non-adrenergic vasopressors? It is indeed probably interesting to consider non-catecholaminergic, non-adrenergic vasopressors that do not use adrenergic pathways, making it possible, on the one hand, to counteract the reduced sensitivity to alpha agonist and the internalization of adrenergic receptors, and on the other hand, to avoid side effects associated with adrenergic stress. It is namely the decatecholaminization concept. And this is the third take-home message of this presentation. Vasopressin is the only second-line vasopressor currently recommended in patients with refractory septic shock, especially as vasopressin deficiency is observed in almost a third of patients with septic shock and is therefore a risk factor of refractory shock. Briefly, vasopressin is synthesized by the hypothalamus, then stored in the post-pituitary gland, and vasopressin exerts pleiotropic effects, particularly on blood pressure via its V1A receptors. To date, vasopressin has been studied in two major randomized trials in patients with septic shock. The first one is the VAST trial, in which 778 patients with septic shock already receiving norepinephrine were included and randomized to receive additional vasopressor treatment, either by increasing the dose of norepinephrine or by adding vasopressin. And the primary endpoint was the mortality rate at day 28. The second trial is a VANISH trial, in which 409 patients with septic shock were included and randomized to evaluate, to compare norepinephrine or vasopressin. And the primary endpoint was kidney failure-free days during the 28-day period after randomization. In the VAST trial, no difference was found in terms of survival. But keep in mind that in a subgroup analysis of the least severe patients, the use of vasopressin appeared to be associated with lower mortality. And in the VANISH trial, no difference was found in terms of number of kidney failure-free days. However, there was less use of renal replacement therapy in the vasopressin group than in the norepinephrine group. But in both trials, the use of vasopressin was associated with a trend toward an increase in digital ischemia. More importantly, in both trials, the use of vasopressin was associated with a norepinephrine sparing effect and a faster weaning of vasopressors. Thereby, vasopressin reduced the catecholaminergic load. How to use vasopressin in clinical practice? A fixed dosage, as in randomized trials, untitrated on clinical response should be considered. Vasopressin is contraindicated in patients with ischemic disease. Regarding the use of a fixed dose, a recent observational study has assessed the effect of an initial bolus of vasopressin before continuous infusion. And the authors found that patients who were responders to the initial bolus, defined by an increase in mean arterial pressure over 22 millimeters of mercury, had more marked changes in the catecholamine index than non-responders at 2, 4, and 6 hours after the bolus of vasopressin, resulting in lower use of steroids after vasopressin administration and lower digital ischemia. The remaining question is the appropriate strategy for tapering vasopressors in patients receiving both vasopressin and norepinephrine. This meta-analysis, including 8 studies, found conflicting results, with the single randomized trial favoring stopping norepinephrine first, and the 7 retrospective studies favoring vasopressin first in order to avoid arterial hypotension. It must be noted that this meta-analysis found no effect of the winning strategy in terms of mortality. What about now the synthetic vasopressin analogs that have a greater selectivity for V1A receptors, namely terlipressin and celepressin? Trials of each have been stopped for futility, and their use may be associated with more ischemic adverse effects. Therefore, they are not currently recommended to manage patients with septic shock. The second non-catecholaminergic vasopressor that could be of interest is angiotensin II. First, because it is the main regulatory system involved in cardiovascular homeostasis. And also because, as with vasopressin, some patients with septic shock have an angiotensin II deficiency related both to a decrease in angiotensin converting enzyme due to endothelial dysfunction and to an increase in peptidase which cleave angiotensin II. This hypothesis was tested in the ATHOS-3 trial, a randomized trial in which 344 patients with refractory septic shock were included and randomized to assess the effects of angiotensin II addition against placebo. The primary endpoint was a proportion of patients with a mean arterial pressure above 75 milliliters of mercury, or who had an increase of more than 10 millimeters of mercury in mean arterial pressure without increasing the dose of norepinephrine. First, as you can see in this figure, the addition of angiotensin II significantly increased mean arterial pressure, but 30% of patients were non-responders to angiotensin II administration. Nevertheless, as for vasopressin, the administration of angiotensin II was associated with a norepinephrine sparing effect, thereby reducing the catecholaminergic load. And it should be noted that there was no effect on mortality and no increase in serious side effects with the use of angiotensin II. Nevertheless, this absence of effects on mortality of angiotensin II administration in the whole population might be related to the heterogeneity of the phenotypes of patients with septic shock. And in this regard, several post-hoc analyses of ATHOS-3 trial were performed in an attempt to better identify patients who would benefit from the administration of angiotensin II. In the first post-hoc analysis, focusing only on patients who required renal replacement therapy, angiotensin II administration was associated with a reduced mortality, but also with a faster recovery of kidney function. In the second post-hoc analysis, the authors have shown that in patients with no increase in plasmatic renin level, meaning with no angiotensin II deficiency, angiotensin II administration had no effect on mortality. Conversely, in patients with increased plasmatic renin level, meaning patients with angiotensin II deficiency, angiotensin II administration decreased the mortality rate. Finally, in this third very recent post-hoc analysis, the authors have evaluated the effects of angiotensin II administration in patients with chronic angiotensin-converting enzyme inhibitor use and in patients with angiotensin receptor blocker use. As you can see, it represents 9% of patients for chronic angiotensin-converting enzyme inhibitor and 7% of patients for angiotensin receptor blocker. In the figure on the left side of the slide, you can see above the mean arterial pressure level within the first 3 hours, and at the bottom, the doses of norepinephrine within the first 48 hours. The blue line represents patients receiving angiotensin II, and the red line represents patients receiving placebo. As you can see, angiotensin converting enzyme inhibitor exposure was associated with increased angiotensin II responsiveness, higher mean arterial pressure level, lower doses of norepinephrine. Whereas angiotensin receptor blocker exposure was associated with decreased angiotensin II responsiveness, as evidenced by a lower mean arterial pressure level and a lower decrease in doses of norepinephrine. And this difference between the two groups of patients might be explained by the differences in biological profile induced by these two medications. Indeed, exposure to angiotensin converting enzyme inhibitor induces an angiotensin II deficiency with high plasmatic renin level and low plasmatic angiotensin II level. Whereas angiotensin II receptor blocker induces no angiotensin II deficiency, as evidenced by non-increased plasmatic renin level and non-decreased plasmatic angiotensin II levels, similar to those of patients who have not been exposed to these drugs. Overall, angiotensin II could be an interesting option, but we still lack evidence. Patient phenotypes and the optimal dosage of angiotensin II have yet to be better identified. Finally, I would like to focus on one last non-adrenergic vasopressor, methylene blue, a guanylate cyclase inhibitor which decreases the production of nitric oxide. To date, only 2 small trials found that methylene blue has an effect on mean arterial pressure, but no effect on mortality in patients with septic shock. And maybe methylene blue could also have a norepinephrine sparing effect, as very recently shown in this small randomized trial including 91 patients with septic shock, in which the authors found that adding methylene blue to norepinephrine shortened the time to vasopressor discontinuation, as well as the vasopressor free days at day 28, ICU and hospital length of stays. But no effect on mortality was observed. Despite these preliminary interesting findings, methylene blue is currently not recommended for the management of patients with septic shock. So, to summarize, it is therefore currently recommended that vasopressin be added in patients with refractory shock without left ventricular dysfunction. In patients with left ventricular dysfunction, inotropes should be preferred. And here, the intensivist has a choice between adding dobutamine to norepinephrine or introducing a treatment with epinephrine alone. And in patients with the most severe left ventricular dysfunction, veno-arterial ECMO should be also considered. But this is out of the scope of this talk. The remaining question right now is, when should the second-line vasopressor be started? Should we start as soon as patients receive a certain dose of norepinephrine with the risk to overtreat patients? Or should we wait a few hours and decide based on patient's evolution, but with the risk of delayed management? Let's back to the literature. Regarding vasopressin, as I told you earlier, remember that in that study, there was no effect concerning mortality and clinical outcomes of vasopressin administration in the whole population. But vasopressin administration decreased mortality in the less severe patients. In this systematic review, the authors found a relationship between norepinephrine dosage at vasopressin initiation and in-hospital mortality. The lower the norepinephrine dosage at vasopressin initiation, the better the prognosis with low in-hospital mortality. And conversely, the higher the norepinephrine dose at vasopressin initiation, the higher the in-hospital mortality rate. And this relationship between the timing of vasopressin administration and patient prognosis was found irrespective of the lactatemia of patients. Regarding angiotensin II, a post-hoc analysis of ATHOS-3 trial found that starting angiotensin II at low dose of norepinephrine, meaning below 0.25, decreased the mortality rate, while starting angiotensin II in patients who received high doses of norepinephrine had no effect on mortality. Thus, rather than considering a predefined threshold value, intensivists should rather adapt their strategy to the evolution of patients and also to the indication for adding a second-line vasopressor. For instance, it will be very harmful to add a second-line vasopressor because of persistent arterial hypotension in patients with persistent severe hypovolemia, it is a differential diagnosis, or in patients with cardiac dysfunction. And when we get back to the international survey I presented to you in the first slides, there is a significant heterogeneity between intensivists regarding the reasons to add a second-line vasopressor. As you can see, it could be a predefined threshold value, it could be the side effects of the first vasopressor, it could be the potential synergistic effects of the two vasopressors, etc., etc. Overall, there is currently no clear answer in the literature, and this question requires further study. It therefore seems reasonable to follow the recommendations of the Surviving Sepsis campaign, which recommends starting vasopressin as soon as the dose of norepinephrine is greater than 0.25 micrograms per kilogram per minute. My last take-home message is that steroid administration should be associated with vasopressors, especially as adrenal or corticotropic insufficiency could be a risk factor for refractory shock. Two major randomized trials have recently evaluated the effects of corticosteroids in patients with septic shock. The French approach trial, which tested a strategy combining hydrocortisone and fludrocortisone, and the adrenal trial led by Anzix, which tested hydrocortisone alone. Both trials had the same primary endpoint, which was the mortality rate at day 90. Approach trial showed a decrease in mortality, which was not the case in the adrenal trial. However, both trials found more frequent metabolic adverse effects with corticosteroids administration. But more important than the effect on mortality is the fact that the two trials showed that corticosteroids enabled faster weaning of vasopressors. And therefore, according to the current recommendations of the Surviving Sepsis campaign, steroids should be started if the dose of norepinephrine is greater than 0.25 micrograms per kilogram per minute, and it has been more than 4 hours since norepinephrine was initiated. In this slide, the management of refractory septic shock and how to use vasopressors is now summarized. In my last slide, I would like to invite you to participate in an international survey of the use of vasopressin in patients with septic shock, which I have the pleasure of coordinating for the European Society of Intensive Care Medicine. The first part of the survey is devoted to the use of vasopressors, and the second is devoted to the use of vasopressin and its analogs. The two parts of the survey are independent, so it's possible to complete only the first part if you do not use vasopressin and its analogs. Individual responses are expected because of the potential heterogeneity in the management of patients with septic shock regarding the second-line vasopressors. And to date, over 800 respondents worldwide have completed the survey. But I need you, so do not hesitate to participate and share the survey with your own network. Thank you very much for this invitation and for your attention.
Yeah, thanks, Dr. Jozwaik. Wonderful hearing that, an update on vasopressors, clinical pharmacology, and their use in septic shock. So may I ask you to stop the share screen, please?
What do you want exactly? Sorry?
Please stop the share screening.
Yeah.
Yeah, great. So the audience is requested to type in their questions. Meanwhile, I can just, kind of start a small discussion so for everybody's sake. So Dr. Jozwaik, sometimes patients come with a marked tachycardia, like heart rate 140 or even atrial fibrillation with fast rate, and they are in septic shock. So do we still go with the norepinephrine as the first vasopressor, or do you think there's an alternative here?
Good question. Yes, right now, even in patients with marked tachycardia, in my clinical practice, norepinephrine remains the first-line vasopressor because I think that patients with marked tachycardia are marked hypovolemia 2, and in most patients, after appropriate fluid administration, it means in patients who are no longer preload reserve, tachycardia not really disappears, but at least decreases, and it is possible to continue norepinephrine administration. But to be honest, I do not really think that tachycardia is really an issue for norepinephrine administration. It could be rather an issue if you find a cardiac dysfunction in your patient because of sepsis-induced cardiac dysfunction, and therefore you asked yourself about dobutamine administration. And yes, it could be an issue in patients with marked tachycardia in whom you end at administering dobutamine. But even in these patients who remain with marked tachycardia and in whom you want to administer dobutamine, there are two cases. The first case is that your patient is still hypovolemic, so that if you administer dobutamine in this patient, you may worsen the situation because you will increase the tachycardia if you do not correct hypovolemia before administering the butamine. But in the second case, if this tachycardia is not related to persistent hypovolemia, but rather to very low cardiac contractility, as evidenced by very low left ventricular ejection fraction, adding the butamine can decrease the tachycardia, because when you administer the butamine, you will improve cardiac function, cardiac contractility, and thereafter you will increase the cardiac output of the patient. And therefore, the compensatory mechanism, which was tachycardia, will decrease, right? To complete my response to your question, it's right that when you administer vasopressin, it has been shown in many studies and meta-analyses that patients who received vasopressin in addition to norepinephrine had less frequently atrial fibrillation. So if the question was, do you think that we can consider vasopressin as first-line vasopressor in patients with atrial fibrillation or in patients with very marked tachycardia? I do not think that to date we have in-house data in the existing literature to answer to this question. It deserves further studies to know. And this is one of the questions included in the survey to understand when and why intensivists considered vasopressin administration.
Yeah, thank you for your answer. So another question, Dr. Jozwik, it partially relates to the receptors that we have, in terms of norepinephrine and epinephrine. Now, let's say norepinephrine is going on at high doses, 30 mics, 40 mics per minute, and the patient has stopped responding. Now, there are recommendations to add epinephrine also in literature. In fact, Surviving Sepsis campaign also says, you can add epinephrine even today. So now my question is, Dr. Jozwik, norepinephrine acts through alpha receptors and beta receptors to some extent, right? Now, when it's going at high doses, all alpha receptors are saturated. In fact, there is downregulation also, and probably beta-1 receptors also, right? Now, if you add epinephrine, does it really increase the blood pressure? Because the receptors are saturated, and epinephrine does have a preferential effect on beta-1. But does it really help here, if you understand my question, in terms of receptors and increasing the blood pressure?
Yeah, I fully agree with you that at high doses of norepinephrine, all alpha and beta-1 adrenergic receptor will be saturated, and that's the reason why you observe no longer effects of norepinephrine at high doses, right? Both for its vasoconstrictive, but also for its cardiac effects. But if you consider to switch norepinephrine for epinephrine, or to add epinephrine to norepinephrine, if I well understood your question, I think that it should not be a good alternative, because epinephrine and norepinephrine are both adrenergic, catecholaminergic vasopressors, and it means that both drugs act on the same adrenergic receptors. So alpha-1 and alpha-2 plus beta-1 for norepinephrine, alpha-1, alpha-2, beta-1, beta-2 adrenergic receptors for epinephrine. So at high doses of norepinephrine, if it does not work, I'm not convinced that epinephrine will work, except in patients with marked cardiac dysfunction. Of course, the inotropic effect of epinephrine is more marked than the inotropic effect of norepinephrine. So it should be interesting to consider epinephrine addition not only as an inotrope drug, but not as a vasopressor drugs. That's the reason why I think that what is interesting is to consider non-adrenergic vasopressors as a second line vasopressor in case of refractory septic shock. And currently, this is vasopressin, which is first recommended, but I think that there is a future for angiotensin 2 or methylene blue agent, right? So my message would be do not consider adrenergic drugs, because if the sensitivity of the adrenergic receptor is decreased, or if adrenergic receptors are internalized in case of refractory septic shock, there is not many chances that epinephrine works better than norepinephrine in terms of vasoconstrictive effects. But it's not the case in terms of cardiac contractility effects because of its more marked beta 1 effect.
Thank you for your answer. So, other question is, the standard practice, like you showed, was to start with noradrenaline and then add vasopressin. Now, sometimes, it happens often. You added norad is going on at high doses. You add vasopressin 0.04 units per minute. The patient is not fluid responsive. The pressure is not coming up. What do you do here now? What vasopressor or what kind of a strategy?
Oh, thank you for this very difficult question. This is the unresolved problem because experts have defined a threshold value of 0.25 microgram per kilogram per minute for norepinephrine to add vasopressin or a second line vasopressor. But it's very difficult because, I think that it is very important to also consider patient's evolution. For me, of course, there is no reason to add a second line vasopressor because the patient has reached few minutes ago the threshold value of 0.25, and the risk would be to overtreat the patients, of course. So that's the reason why I think we should a little bit wait before administering a second line vasopressor. But on the contrary, of course, if you wait too long, the risk is that appropriate management will be delayed, and what you observed at the bedside, and what I observed at the bedside, is that if you add vasopressin too late, so it does not work and patients die. And that's one of the reasons why many intensivists say that vasopressin does not work so well in patients with septic shock, because they add, in fact, I think, vasopressin too late, right? And when the patient is too sick, too severe, whatever you add, nothing will work because the patient is too severe, So it's not vasopressin which does not work, it's rather that the administration of vasopressin was too delayed. But of course, how to do it in practical? I think, first of all, it is very important to avoid hypovolemia, right? If you vasoconstrict vessels in a patient who is hypovolemic, it does not work, and you will induce ischemia, tisular ischemia. So the first step is to eliminate persistent hypovolemia, and to this end, you can test with many dynamic tests. Irrespective of the test you use, you can test the preload reserve of the patient. And if your patient is still preload reserve, I think that there is still a place for fluid administration before considering adding a second line vasopressor, right? But if your patient is no longer hypovolemic, your patient has no cardiac dysfunction, of course, just wait few minutes or maybe 1 hour, right? And if you continue to increase norepinephrine doses, I think that this is an indication to start vasopressin, right?
Thank you for your answer. So now just one more question about vasopressin. Vasopressin is known to cause hyponatremia. We see it all the time in medical patients, and here we use vasopressin in high doses. But in most of the trials, there has hardly been any hyponatremia. So that is very interesting. To my knowledge, I think it occurs, or what the literature says, is because of downregulation of the V2 receptors on the renal tubules, where vasopressin acts and is supposed to cause a lot of water retention. But is that right? Because this is a very clear observation. It does not cause hyponatremia. So is there an answer to this?
Yes, yes, you are right. You are right. This is a theoretical side effects of vasopressin when vasopressin is administered at high doses. But when you look at the different trials using vasopressin, hyponatremia was never related as a side effects of vasopressin because, as you say, there is a downregulation of some receptors. Side effects of vasopressin are really ischemic effects, and especially mesenteric ischemia and digital ischemia. That's the reason why vasopressin is only contraindicated in patients with vascular disease, but it's not contraindicated in patients who have some metabolic side effects such as hyponatremia, which is quite frequent in critical ill patients. So hyponatremia is not a contraindication to administer vasopressin in critically ill patients because you will not observe these side effects when administering vasopressin in patients with septic shock.
Thank you for answer. So just a final question, Dr. Jozwik. We know about the beta 1 and beta 2 receptors, but there is also beta 3 receptor. This has been around for a while, and I think it's found in a large amount on the cardiac tissue. So where does beta 3 receptor stand in terms of catecholamines, norepinephrine, epinephrine, and their mechanism of action? Beta 3 receptors.
So your question is about the beta receptors and the effect
beta
of
3, beta 3.
Beta 3. Oh, wow. Beta 3 receptors. Yes, of course, they are involved in the different cardiac effects. But when you use norepinephrine or epinephrine, so you do not target this beta 3 receptors. So it means that it's not really an issue for the cardiac effects and the vascular effects of norepinephrine and epinephrine in patients with septic shock.
Yeah, thank you. So just a final question. Are you using methylene blue or angiotensin 2 in France?
Good question. But I think it would be very interesting, especially in the light of the recent literature on this topic. But methylene blue is not available in Europe, so in France too. So I cannot use it.
Okay.
This is a very, very old drug. So methylene blue was used a few years ago, but currently it's no longer possible to use it, except when you consider to use it for a trial.
Yeah, no, the one problem with methylene blue will always be that the saturation cannot be monitored. So if the patient is hypoxemic, that's a big problem.
Yeah, sure. And the other problem from a research point of view is that it's absolutely impossible to blind your trial because you can see the blue color of urine.
Yeah, okay. So thanks so much, Dr. Matthew Jozwik. Wonderful, really nice listening to all that you said. An update on vasopressors, a great audience we had, and I think everybody would have loved that. And it'll be up there on our YouTube channel, and it'll be posted there. So it'll be available to all the young intensivists in the world. And please send me your survey. I'll put it up on the site. Thank you so much.
Thank you for your invitation. It was a pleasure to be with all of you. Thank you so much.
Bye.
Bye-bye.